Our last topic in pulmonary rehab is physical conditioning. It is defined as an activity that increases intensity, duration, frequency, or workload. Patients should be monitored for symptoms and discomfort, and documentation of progress must be made. Progress may be defined as increasing repetitions for strength training, higher level of work within a given time period, fewer rest periods needed to complete tasks, or decreased dependence on adaptive equipment. The goals of physical conditioning are aimed at increasing cardiorespiratory endurance, maximizing work capacity, and improving strength, flexibility, and respiratory muscle function. Endurance training should incorporate a target frequency and duration of exercise, a mode of exercise such as walking, cycling, arm ergometry, arm lifting exercises, step exercise, rowing, swimming, water or land-modified aerobics, and seated aerobics. Proper warm-up and cool-down should be included with each session. Frequency should be targeted for 3 to 5 times per week for 1 to 2 hour sessions over 4 to 72 weeks. Intensity of exercise should be related to the patient's ultimate goals. For instance, if a patient wants to be able to walk their dog for 30 minutes at a slow and steady pace, then exercise should be tailored to meet that goal. It should also be set up to a specific time interval and workload while watching physiological responses. A target heart rate should be determined by age-predicted maximum heart rate and level of functionality, with medications at slow heart rate being taken into consideration. It is important to optimize use of bronchodilators and other pharmacological therapies before and during an exercise program. Supplemental oxygen, if needed, must be monitored for proper titration during exercise. Upper and lower extremity training should be incorporated with special attention to balance and coordination to decrease fall risks. Lower extremity training incorporates walking, stationary cycling, biking, stair climbing, or aquatic therapy. Since these use large muscle groups, these exercises dramatically increase exercise tolerance in COPD and other respiratory diseases. In addition to endurance training, strength training is beneficial for patients with chronic respiratory diseases. Lower extremity training may include cycling, stair climbing, bench stepping, and walking. It should be started with low resistance and progressed with increasing repetitions before adding more weight. Upper body training requires more ventilatory work, and patients are more likely to hold their breath or develop asynchronous breathing patterns and dyspnea. This is due to the activation of accessory muscles that are located within some of the arm muscles. The benefits of upper extremity training include improved strength and endurance, reduced metabolic demand, and increased sense of well-being. Rotating strength training between lower and upper extremities may improve tolerance. A particularly good exercise for both upper and lower strength is the chair sit to stand or chair rise test. Monitoring a breathing pattern, pulse oximetry, and blood pressure are important during strength training, and documentation should include amount of resistive load, weight, number of repetitions, all recorded vitals, and the ability of the patient to carry out employment-specific recreational or daily activities for each session. Many patients with chronic respiratory disease have significant changes in posture and reduced muscle flexibility. This can result in inactivity or structural changes in the chest wall with hyperinflation and hypertrophy of the accessory muscles. Gentle stretching, particularly yoga movements, when combined with breathing exercises, are most helpful. Due to the high incidence of osteoporosis in pulmonary disease populations, caution should be taken when incorporating trunk flexion with rotation into exercise routines, bending forward at the waist and twisting. Respiratory muscle exercises along with endurance and strength training may improve patients' workup breathing. Diaphragmatic breathing, pursed lip breathing, or inspiratory muscle trainers that use resistive force and improve inspiratory muscle function may all be added to the rehab plan. Inspiratory muscle training, IMT, must be a lifelong training program, as benefits diminish over time when not used. It is important to note, however, that the Association of Cardiovascular and Pulmonary Rehabilitation, AACVPR guidelines, do not support the routine use of IMT as an essential component of pulmonary rehabilitation. Exercise performance varies with the severity of disease, and programs must be tailored accordingly. Classifications of mild, moderate, and severe respiratory disease are determined by pulmonary function tests, symptoms, and exercise tolerance. One of the best models for identifying stages of obstructive lung disease is the Global Initiative for Chronic Obstructive Lung Disease, GOLD guidelines. Patients with mild disease are defined as FEV1 greater than 80% predicted, normal ventilatory response to exercise, normal ABSs with either normal or slightly decreased PaO2. Patients may exhibit shortness of breath with such activities as climbing hills or stairs, but are usually asymptomatic with ADLs. The only symptoms they may exhibit are chronic cough or sputum production, a history of smoking or occupational exposure. Patients are usually not recommended for pulmonary rehab at this stage, but will benefit from an exercise program developed for a normal population. Patients with moderate lung disease are defined as FEV1 below 80% and an exercise tolerance that is limited by ventilation. The patient becomes short of breath with usual ADLs and with moderate to fast walking pace, approximately 3 to 4 METs. Mild to moderate hypoxemia will be exhibited on an ABG at rest. An episode of acute illness, exacerbation COPD, such as an acute pneumonia or pulmonary complications after surgery, may identify these patients, and rehab at this stage can modify risk factors and decrease the likelihood of future pulmonary complications. Progressive exercise programs should be initiated, and careful monitoring of ECG, blood pressure, heart rate, and pulse oximetry should be monitored with either a progressive exercise protocol or a 6-minute walking test. Supplemental O2 may be needed to maintain SpO2s greater than 88%. Patients with severe lung disease may be restricted by symptoms or shortness of breath for most ADLs, even walking at a slow pace. FEV1 will be less than 50% of predicted, and the patient may require either intermittent or continuous O2 at rest or with activity and have elevated PaCO2 on ABG, along with moderate to severe hypoxemia. A 6-minute walking test may be utilized to assess functional level and exercise tolerance. Monitoring the patient for desaturation and arrhythmias is important for this test. Patients in each category should be monitored for pulse oximetry, dyspnea and exertion scales, heart rate, respiratory rate and pattern, and resting and exercising blood pressure. All patients should gradually require less supervision and monitoring as rehabilitation goals are met and patients gain more independence and self-regulation. When this occurs, a patient may be ready for discharge from a supervised therapy to an independent exercise program.